Yes.
Okay,
absolutely.
okay, guys. This is an important drawing that I'm going to share with all of you, which is the principle of functional anatomy. Functional anatomy means that the blood vessels are not just hoses. They work in a fashion that depends on demand. There will be more flow, less flow. If there is a narrowing in one side, then the other side will compensate. So you have a flow that can be antegrade, could be reversed, could be reflux. But when you look at an angiogram, don't look from the center to the periphery. That's the classic way of thinking. Yes, that tells you if you have a common carotid injection or not, of course. It tells you if you have an AP or a lateral. All those things make them conscious. But when you're trying to reconstruct the anatomy, if you have a nose, you must get blood supply to the nose. It doesn't matter if it comes from below. Can you see the arrow in the video?
Yes.
It doesn't matter if it comes from below,
Yes.
or it doesn't matter if it comes from above, but you have to receive blood supply to the nose. So we're going to look at anatomy from the periphery backwards to the center. And we're going to then try to reconstruct the anatomy. Another principle is, I think it's called angiosomes. Angiosomes are territories that are usually supplied by a pedicle, by a vessel. And the angiosomes can occur almost everywhere in the body. Certain exceptions are the kidney and the lungs that have more terminal arteries because they are lobules. And biologically, they are different entities that get put together. In the head and neck in specific, there is certain constants that we're going to use, and those are the bony foramina. The bony foramina is a constant. It doesn't change. It may be larger, it may be smaller, it may be absent. If you have an absence, the carotid never developed, you're not going to have a carotid canal. But for the most part, those are constants that permit us to understand the functional anatomy. So in this drawing, Dr. Lajeunesse, who developed this functional anatomy, created this concept. And the same color that you see in the representation of the face, you see it in the blood vessels of the external carotid artery. So this is the maxillary system which supplies this part of the body. And here the constants is the orbital foramina, infraorbital foramina, the cavernous sinus, the here in the malar region are the constant things where anastomosis will occur. The pharyngo-occipital in green has a relationship with the pharyngeal in face and the maxilla, and of course the posterior fossa of the brain through the C1, C2, and C3, and then comes also in the cavernous sinus through the ascending pharyngeal artery coming into the foramen lacerum. Okay? So that is an important, and here we have all those anastomosis which we will be seeing. The facial area has relationship with the maxillary area, but also with the thyroidal region. And then the cervical region will have relationship with the ascending pharyngeal and the occipital arteries. So that functional anatomy, this drawing is very, very helpful because it will give you the foramina. Like we have a foramen here, you know what this one is? Okay, let's go backwards. What artery can you tell me is this one? What do you think this artery may be?
Probably carotid.
No.
Oh, sorry.
This is a common carotid.
Oh, okay.
We chop off the internal carotid artery.
Oh, this is.
Patient had a stroke.
Yes, this is MMA with that.
Oops, sorry.
With that sharp turn.
Huh? No. You know which artery, when it enters the skull, has a sharp angulation?
MMA.
The middle meningeal artery, okay? So this circle is the foramen spinosum. Then this is the accessory meningeal to the foramen ovale. And then this is the the foramen rotundum, which goes from an anterior to posterior position. So this, what happened? Sorry, I got a very sensitive mouse. Anyways, so what this will be is this is the other side. If I put the internal carotid artery here, what vessels will anastomose with this middlemeningeal, accessory meningeal, and artery foramen rotundum?
Infralateral trunk.
The infralateral trunk. So now you understand that there's a balance. In general, the brain is the winner. If there's any problem, blood will go towards the brain. But if there is a ligation at any place, there will be flow from the brain down through the infralateral trunk, or through the ascending pharyngeal, or lower down through the occipital. And then we have the orbit. Okay? So I'm going to share this drawing with you guys. It's in the book. I was trying to find out the legends. I have it somewhere. But we'll email to you to all the fellows, okay?
Sure.
So you remember this drawing. If you're able to dominate this drawing, you're going to be safe. We have I'm developing a lecture. There's going to be a fellow course from Serranova on, it's going to call Truefield. You know, I meet with Dr. AJ Wakalu and myself. So we're going to do anatomy, and we're going to do the principles of NBCA and all stuff like that. So when I have all those lectures, we'll do part of that. Will be you guys will get the lectures too. Okay? Okay. So this is from last week what we were missing. Okay? So we're going to hold that, and after we finish, you and I going to send it to the fellows. Okay?
Absolutely.
Okay. Tell me when you're ready.
I'm ready. Okay,
good. So we have this lady is 50-something years old. Who started having some weakness on the right upper extremity. We treated in the past, but we're not going to get into. And what I put here is, what are you looking here?
This is the vertebral artery.
It's the right vertebral artery.
Neck view.
Neck view. This is the AP view. This is the lateral. Okay?
Yeah.
And what you see here, you know what this is? This blood vessel here?
So it...
Which is this blood vessel here?
I mean, ends to a blush. It looks like a thyroid blush. So I think...
No. The thyroid is down here. The vertebral artery does not give thyroidal arteries. The thyrocervical trunk, the supreme intercostal, may give you thyroidal arteries, but not the vert. Okay? This is called the artery of the cervical enlargement. The primary blood supply to the cervical spinal cord comes from C6 or C3, which is called the arteries of the cervical enlargement. The cervical cord is wider there. And then it receives, this is from the ventral aspect, then it receives a blood supply coming from the pica and or vertebral or VB junction called anterospinal artery, and then off the vertebral what is called the lateral posterior spinal artery. Okay? And there is the circle of the spinal cord, like circle of Willis. But we're going to do the circle of Willis of the cervical spinal cord today. When you look at a film like this, it is not bad to put some bone, at least if you're planning surgery or you're working with a surgeon. So we're going to put some bone. I'll put it here first. But I had some pictures that we put the bony landmark. Okay, here. Okay, so this is the same. It's the same angiogram, but having a background, anatomical background. Okay, so what you see, and that's how important this is. Okay, here is that when you're looking at this picture, which is the same as this picture, you realize that this is the frontal portion, the ventral surface of the spinal cord. So here is the anterior spinal artery, and this anterior spinal artery will anastomose with this artery of the cervical enlargement, okay? This is the posterolateral, and there is usually one on each side. Obviously here is markedly enlarged, right?
Yeah.
Because it's supplying a high flow arteriovenous malformation. Okay? This artery, either you see it or not, will anastomose with these very small arteries. Okay? When you're looking at a picture lateral like this, there is another vessel that you see here. Tomoyoshi, you know who this one is?
Odontoid?
The odontoid process. Okay? The odontoid process is the ascending pharyngeal artery. When it projects posterior to the vertebral artery, it is the anterior spinal. When it projects at or anterior to the vertebral, is the artery of the cervical enlargement. Okay, this is a very good thing. Can you see the odontoid process here? Can you see the artery of the odontoid process?
So on 80, is it the one just above the origin of
This one.
posterior? Oh.
It's this one.
Oh, it's ascending.
Yeah, well, it got to go. It's go on this side, then it would turn around. This is the odontoid, right? C2.
Yeah.
So the artery of the odontoid anastomosis what to what? Why is it important?
I think it's the connection between anterior and posterior supply, arterial supply.
No, don't get confused. The odontoid process is the posterior branch of the ascending pharyngeal artery. Okay, this one I do have it here. Okay, so in anastomosis, okay, where are we?
It's probably ECA to
The vertebral,
vertebral.
okay, to the external carotid artery. So if you're doing the odontoid, I have very good pictures of that. Okay, see, here's the odontoid process. Okay, this is the odontoid.
Does it share here?
Here, I'm gonna make it bigger. Wait, I may have it bigger. I may have it here.
Yep, absolutely.
Oh, nice.
So we have the anastomosis from the number 8 here is the vertebral artery. This is the odontoid process, comes up like this, right? And then you have the ascending pharyngeal artery, comes up like that. Oops. This is the odontoid process, and in this upper part is going to the hypoglossal foramen. Okay? So the importance of this odontoid process is number 1, anastomosis between vertebral and external carotid. So if you're embolizing a posterior dural fistula, you have to make sure it doesn't happen. And what's the other part which is important in this anatomy? There is the odontoid process and the ascending pharyngeal, and then there's the neuromeningeal branch. And what does the neuromeningeal branch supply? The lower cranial nerves. Okay? 9, 10, and 11. And when it goes to the hypoglossal canal, the 12. Teeny weeny vessel, tremendous importance. In this drawing, there's another branch going anteriorly and superiorly. Is the artery foramen lacerum. And it's going to anastomose the ascending pharyngeal artery with the internal carotid artery. So that little ascending pharyngeal artery, 9, 10, 11, 12 cranial nerve. Anastomosis with the vertebral, anastomosis with the internal carotid artery, anastomosis with the other side. So you can get to a lot of trouble embolizing and not understanding that artery.
Next time that I inadvertently go into ascending pharyngeal, I'll try to respect it more.
Yeah, you inject and you can inject. Don't inject too aggressively because you're gonna reflux, not gonna understand anything. If you want to understand a vessel, you want to know if it's feeling something. Actually, we have a very good example in this case. We'll show you that in a second. Okay, so look how much information there is in this picture. And we didn't get into the meningeal branch of the pica, but we're going to leave that for the time being, okay?
Sure.
Are we clear what's going on this side? And here we have the same thing with the superimposed bone,
Yeah, absolutely.
okay? Now we're going to go to the opposite side. One more thing here in this anatomy. Here Tomoyoshi injected. Look at the difference of, can you tell me what this is? I'll give you a little bone here for being nice.
Sorry, which one?
What artery is he injecting here?
Looks like a
Doesn't look like
cervical-
it is or it's not?
cervical trunk.
Does he look like Tomo?
With mask, I have to, I have to see.
This is the thyrocervical trunk. And the thyrocervical trunk and the costocervical trunk could give blood supply to the cervical enlargement. That's the other anastomotic pathway, okay? But this is a typical curve of the thyroidal artery. Okay, this is called the inferior thyroidal. The superior thyroidal comes from where?
It is it's the first branch of external.
From the external carotid artery, okay? Now, what we see here in this injection is there's something going to the AVM. There's something here peculiar. We'll have to analyze it. And you see, there's some, you see that? This is not normal.
Yeah.
So we're gonna have, see, a bolus injection like that is not good enough, right? We can't tell exactly. And there's a lot of potential danger. This could be anterior spinal artery. There's a potential, okay? But that's how we work out the right side. And what we did is we went ahead and catheterized that vessel to get some answers. Oh, one more thing. One more thing. But I will do this at the end. Okay, where is our injection? Okay. Okay, so we have, this is the vertebral, see, but he refluxed too much, so it became confusing. But we have the posterolateral, anterior spinal, yes, artery of the odontoid process, yes,
Yes, absolutely.
and here you see it like in this drawing. This is the occipital, this is the dorsocervical. So this anastomosis here, you see it here to the cervical. This you see, anastomosis here, and goes to the odontoid. Okay.
Yeah, absolutely.
Okay, and now we're going to analyze a little bit better this one. So here we see the thyroidal, and here we have the catheter in that selective injection, and now we see, and this is all collateral, probably I embolized this years ago, and this is not a regular vessel, but it follows the nerve root, okay? This is the exit of the nerve root, and the question would be, how do you prove it? How do we know if it's intraspinal, if it's intramedullary, if it is in the nerve root, if it's in the, how do we do that? How would you work this thing out? Angiographically, you're faced with this problem. What do you do?
I mean,
What options do you have for imaging? I want to know what this is. The surgeon wants to know where to take this out.
one is just superimposing with bony structure.
But it only gives me this. I'll give you the bone. But it's not going to help, unfortunately. Here's with the bone. Okay, there's the bone. Can you tell me?
Yeah, the other thing is if it is following an anatomic structure, it looks like that anatomic structure.
You got a fabulous machine. Most people don't use it, unfortunately. You got a fantastic machine. We did something different.
3D.
Yes, we did a rotational angiogram. Let's see if they put it in. Okay, this is. Okay, this is the other side. So let's go. What we did is a 3D, and then we did what's called 2 volumes. So we put the bone, we put the vessels, and then we looked at it like this. And actually we could see how it goes out right in the nerve root. Okay, but well, right then. So to work this out, we finished doing 3D. And then we'll show you how I work out the spinal cord. Okay, so this is how we work this part. But so there is one nidus here and there's another nidus down below. Okay, now we're going to analyze the opposite side, okay? Clear?
Yes, absolutely.
Okay. So we're going to do a similar situation here. So that's the right. Okay, so we're going to go and I'm going to take and go back to 2 on 1. So I'm going to take and put first. This is the. Okay, so what we have here is the left vertebral artery. Yes?
Yes, absolutely.
Okay. Bless you.
Thank you.
Okay, here is the dorsocervical, ascending cervical. There was no supply from it.
That was a costocervical trunk injection.
Sorry?
So the dorsal cervical was a super selective injection? or-
Yeah, here is the case. You know, Tom will use a little bit too big a catheter. But okay, but here's the subclavian, but we have this artery. What is this?
Cervical.
Look. What? Look at this.
Thyroid?
Yes. This is the, see how different it is from the spinal artery? And this is a typical blush of the thyroid, normal thyroid gland.
Mm-hmm.
Okay, no spinal cord supply. Okay, you do see some of the anastomosis that we saw before, but you know, if you wanted, let's say you wanted to inject and see the anastomosis here, you would inject like 1.5 cc's or 2 cc's per second for 10 seconds. So for a low period, so you feel it, okay? Whenever you want to see that type of, okay, so there's no supply. So this, what we're working out is this part, all this part of this anatomy, okay? So we work the right side, we then work the left side, okay? There's no question that this is the true supply or the main supply to this malformation, okay? What is this one? How did it feel?
So it comes off near pica, and I think that's anterior spinal.
Does it look familiar to you? Have you seen it before?
Yes, maybe posterior spinal.
You saw it before,
Yeah,
yes. Same.
posterior spinal. Sorry.
It's the same artery. Right?
It's a contralateral side.
Of
or?
course. No. Look what happens. Look what happens. It goes
Oh,
up
yes.
like this.
Yeah, same one.
It turns
Yeah.
around, right?
Absolutely, yes.
It's exactly the same. See the same curves?
Yeah, exactly. Yeah.
Exactly the same. But you and we were going to use the mini scepter, but we decided to try the regular scepter. Okay, so there's the scepter. And now we have flow control. Why do I say we have flow control? What can you tell me what's going on here?
There's a balloon which is inflated.
There's a balloon here. Okay? But look at this. This is stagnant. This blood is not moving.
Correct. Yeah.
Okay? And look what happens. Now we have flow control. But look at this. Look at I'm going to play it back and forth and tell me what do I have to be careful of. Don't look at the disease. Look at right here, this point. Look at this point.
Oh, there is a small branch
Yes.
on the side that
But
is.
it's telling me that I have flow control over this segment. Right at this point, I have some type of anastomosis coming.
Because you have washout.
Right. So if I inject harder, I have higher pressure, I go back. When I let inject, it goes back in. So I know that this is going to be important how the onyx is going to behave. Okay?
Absolutely.
You understand the subtleties of all this?
Yes. Yeah.
Okay. So now, with that, yeah, this is that I'll just. So here is the. I hope I saved it. Okay, there comes the onyx. Turns around. Ah, you see exactly what was predictable.
Yep.
So you stop here injecting. We want to now let this harden so we get an antegrade flow. Okay? So this is the next injection. It still goes back, see? even another branch. So we just stop and wait.
How much do you weigh, Dr. Bernstein? Like
0.2, 0.3 cc's.
30 seconds
Huh?
or 30 seconds to 1 minute, I would say.
Okay, I now
Yes.
didn't save the date. Okay, here now that this has now it starts on penetrating. Now we get the fistula. Here we're trying to get a little bit more sound coming towards the balloon. Okay, we have to be careful. Look. Okay. We get a little bit more into the. So we got a very nice. This is now the injection with the balloon. No, this is.
Control engine.
Is here. So here we deflate the balloon. We didn't want to get it all a full cast because we don't want to get this thing was pressing on the nerve. Okay, this should actually work. So this is the post-embo of that. And then we went to check the spinal cord, which we had agreed with Dr. Gatan for surgery. But here we come, and look what happens. The guide wire goes down like that. And here is the bone. So this tells you, careful. Almost done, bitch.
Okay. We have some clinics starting at 9.
I know.
Thank you.
Okay, so now we went with the microcatheter, and we got to this position. Say, hey, fabulous! Look, we got a straight shot to that fistula. Remember, we said that we knew already what the fistula would look like. And now look at this. There's the fistula. Remember that same structure?
yes, yes.
Look at this lateral view. Look how piece of cake, right? We got it.
Yes.
Now we inject a little bit harder. The same principle. So, any worries?
Yes, it looks like probably anterospinal is backfilling.
Probably, surely. it
Definitely, yes. Yes.
is. Now, if this patient would have bled or had problem, we could do something like go inside here, and try to close it here. But if you reflux, you paralyze this patient.
Correct.
So we backed off. Okay? Although you didn't see this artery in the angiogram of the vert, yeah, you don't see this artery in the vert. You see?
I think because you did, you were able to focally increase the pressure.
You actually see it, but coming from above.
Yeah.
Okay, look at this. Look at this thing here. Exactly the same.
Yeah, absolutely.
You see it?
Yes, yes.
Take those two pictures, and now you got the functional anatomy of the cervical spinal cord.
Perfect.
Huh?
That's great. Thanks so much, Dr. Bernstein.
Pretty good. Nice case.
I'll
Okay.
make sure the 3Ds.